When spectral Doppler was introduced into clinical practice, a lot of people actually said it's a useless technology. And I remember some people at our clinic refused to use it. And then it became clear that with the help of Doppler, you could actually quantify lesions. And even when color Doppler came around the corner, many people said, well, what do we need that for? Now we have spectral Doppler. Today, we use both spectral and color Doppler in a routine exam in many imaging positions. And that's exactly what I'm going to show you in this presentation. Before I show you where we use color Doppler, let's take a look at the settings first. A very important part is the so-called color bar, which you will usually find somewhere on the right-hand side or left-hand side of your screen. It's a bar that displays exactly how the color settings are adjusted. First of all, you will have a number on the top and on the bottom. This number depicts the so-called aliasing or PRF velocity. In other words, above a velocity of 62 centimeters, you will have the typical aliasing phenomena. This is important because now you can put these colors into relation with the actual velocity. The other important part is the color scale here, which shows you how different velocities are actually displayed. For example, red would be, of course, towards the transducer, and if it turns yellow, the velocity will get higher. And in some machines, you can even set the velocity so that you have turbulence flow marked as, in this case, a greenish color. This is very important because, as you will see, the color will look very different on various machines. In general, very important consideration, you need good image quality to also get good spectral and color Doppler quality. Here's a beautiful example that illustrates this. On the left-hand side, poor image quality and only a very small MR jet. On the right-hand side, much better image quality, and all of a sudden you realize that the patient actually has severe mitral regurgitation. So always optimize your 2D image before you use either spectral or color Doppler. I'd now like to show you the standard protocol of using spectral and color Doppler in echocardiography. And here we usually start with a parasternal long axis view, and that's also the first place we'll use color Doppler. We'll look at flow across the aortic and the mitral. You might question yourself, why are we using color Doppler here, especially since we have a more or less perpendicular orientation to the flow, both the aortic and the mitral valve? Well, the reason is you still see the jets, and that frequently eccentric jets, and in this case, you will really get the best recording from these views. An important tip, don't place one large color Doppler box across both the aortic and the mitral valve, but use a smaller box and use two projections, one specifically for the aortic valve and one specifically for the mitral valve. Why? Because that increases your frame rate. Now, in this specific case, we don't see anything across the aortic valve, which is abnormal, but we do see a little bit of a regurgitant jet here in the region of the mitral valve. So this will help us to detect these pathologies. Let's take a look at where else we can use color Doppler in the parasternal long axis view. As mentioned, aortic regurgitation, aortic stenosis. Here you will see turbulent flow or flow acceleration at the region of the aortic valve. Mitral regurgitation, as we saw in this specific case. Mitral stenosis, here we will see a turbulent inflow into the left ventricle. And LVOT obstruction. As a matter of fact, this is a perfect view to determine whether or not flow acceleration actually happens at the valve or below the valve, because in this case you will see flow somewhere down here. And finally, you can also detect a ventricle septal defect, even though this is probably not the ideal view to visualize a VSD. The next view where we're going to use color Doppler is the parasternal short axis view, where we are visualizing the pulmonic valve. Here is a beautiful example of pulmonic regurgitation. Again, we have a very small sector to really capture the high frame rate. And we see this in probably most of our patients. If you just look closely, you will see PR in most of our patients. But there's also some pathologies that you can detect here. For example, a patent ductus. Here again, we have pulmonic regurgitation. This is maybe moderate or maybe mild to moderate. But here we also have a second jet, which originates from the aorta and where blood flows right into the pulmonary artery, both during systole and diastole. So this is a typical PDA. This is actually the view where you can probably best visualize a PDA. What other indications do we have for color Doppler? of the pulmonic artery and the pulmonic valve? Well, regurgitation as we saw, but also pulmonic stenosis. In this case, what you will see is you'll see turbulent flow across the pulmonic valve. We can detect RVOT obstruction, then you'll have the flow acceleration somewhere up here. And as already mentioned, the PDA. Now let's turn to spectral Doppler. Before I show you where we use it, let's talk about the settings first. Remember, we have a so-called zero line, and we have to adjust the zero line so that we, of course, accommodate for the direction of flow. In this case, we have a patient who has flow away from the transducer. Therefore, we have the zero line moved to the top. And then we have, of course, the velocity of the tracing, where we can stretch or more narrow the settings here. If you have a patient where you want to have many beats on the screen, obviously you will have to have a low velocity. If you have a patient where you want to look at a signal in more detail, you will take a higher velocity. Let's move back to the pulmonary valve and the pulmonary artery and take a look at where we use pulse wave Doppler here. Well, we place the Doppler sample volume usually in the region of the pulmonary valve or in the pulmonary artery. Now I know there's some discussions as whether or not you should put it into the RVOT or not. I usually do not recommend this for a very simple reason. Take a look at this reference image here. You will see that the flow is more or less perpendicular here and then it is parallel. And if you place it in the RVOT, you will not be parallel to the interrogation and therefore you might not get the maximum velocity. The other problem of placing it into the RVOT is that in this case, it's very difficult often to measure the distance here, and you will need that, for example, for shunt calculations. So my recommendation here is to place it into the valve or into the pulmonary artery where you can really measure the distance here as well and where you have a parallel orientation. In any case, it is important to get a curve where you have a very good envelope. In other words, where it's easy to delineate the beginning and the peak of the curve. Why do you need that? Well, if you want to look at the so-called pulmonary valve acceleration time, as we're doing here, it will be important. So here we are now measuring the distance between the moment when flow starts, this is usually a very sharp signal, and the peak of the curve. And this measurement will help us to, I would say, estimate pulmonary pressure to some degree. We'll talk about that later. So try to get a good velocity envelope in pulse wave Doppler of the pulmonary valve. What is the normal velocity? Well, it's somewhere between 0.5 and 1 meters per second. Where do we use this? We use it for RV flow calculations. So, for example, if you want to look at shunts, left to right shunts or right to left shunts. It will help us in pulmonary hypertension, as I just showed you, with the help of the PVAT. And it also helps us to look at pulmonary stenosis, even though if there's truly pulmonary stenosis, the velocity will be higher than 1. You'll have aliasing, and you'll usually need to use continuous wave Doppler. In summary, if I image the pulmonary valve, I always use color Doppler. I always use pulse wave Doppler. And if I do see that there's some degree of flow acceleration or turbulent flow in the color Doppler, then I would also use continuous wave Doppler. Now we're at the short axis view at the level of the aorta, in other words, at the base of the heart. Again, we use color Doppler here. Why? Because we want to see, for example, if there's some degree of regurgitation at the aortic valve. This view is ideal to look at the origin of the jet. You see a very small little jet here right at the center of the aortic valve. This is a trivial or trace aortic regurgitation, but it just demonstrates that it's very nice to see in a short axis view. What else can we see in this view? Well, since we're also very close to the LVOT, it's possible to detect a ventricular septal defect. As a matter of fact, it's one of the best views to not only detect the VSD, but also to differentiate which type of VSD it is. We'll talk about that in the chapter on congenital heart disease. Here is an example, though, of a patient who has a perimembranous ventricular septal defect. You see the turbulent flow and the aliasing that goes from the LVOT into the right ventricle right here. And then finally, you can also look at an atrial septal defect. Now, if you want to look at an atrial septal defect, however, I would recommend you to use a little bit of a modified view, which is displayed right down here, where you're somewhere between a 4-chamber view and I would say an apical view and a peristernal view. Here you see the jet that comes from the left atrium into the right atrium, you have a better orientation to the interior septum than from a four-chamber view because you have a more perpendicular orientation to the ASD and a more parallel orientation to the flow. Finally, we also look at tricuspid regurgitation here because we do see the tricuspid valve, and in some patients this is actually the best view to depict TR and also sometimes the view where we get the highest TR signal. So this is the way we use color Doppler in the peristernal views. Does it make sense to use color Doppler also in the short axis view at the mitral valve? Well, if you want to become a master, and I assume you do want to become a master, yes, it definitely makes sense. Because here you will detect MR jets that might not be visible in any other view. Here you have a short axis view, an example of a patient where we see a so-called commissural MR jet. In other words, the origin of the jet comes right here at the border between the anterior and the posterior leaflet in the so-called, in this case, posteromedial commissure. Now, you see that the jet comes here and moves here towards the middle of the ventricle. If you use a normal four-chamber view, you might not even see this jet. And this is why color Doppler in a short axis view is very important. It helps you to show where the origin of a jet is. We're now moving to the apical views and to the four-chamber view. Obviously, you're going to use color Doppler here as well. Again, we have a very narrow sector, and we're focusing here on the mitral valve. In this case, we, of course, tilt the transducer up and down a little bit so that we really scan the entire mitral valve for usually mitral regurgitation. That's what we're looking for in most patients. Here's an example of a patient who has massive mitral regurgitation. And by moving the transducer a little bit back and forth, we try to really get the full extent of the jet. So what you do when you image these patients with MR is, first of all, try to find the spot where MR is most and also get a little bit of a feel how much motion you have to do to lose the jet. The more difficult it is to lose the jet, the larger it usually is. So let's summarize. What can we detect in a four-chamber view? Mitral regurgitation and obviously also turbulent flow of mitral stenosis, the so-called candle flame. Again, we'll talk about that in the chapter which deals with this pathology. I already mentioned that we can detect an ASD with the help of color Doppler and that we usually use so-called angulated or atypical views to demonstrate that. But of course, you can also see an ASD in a four-chamber view, but it's much more difficult. What do I do in such situations? Well, I always scan the interatrial septum in each patient, and if I have the suspicion that an ASD is present, I usually use atypical views as well to demonstrate that more clearly. As a matter of fact, you also see a beautiful inflow from the pulmonic vein here in this four-chamber view. This would also be an ideal way of looking at this flow phenomena as well. In summary, when we look at the interatrial septum, we're going to look at PFO and an atrial septal defect. One more word to the patent foramen ovale. Yes, it is sometimes possible to also detect the PFO, but the sensitivity of color here is of course not as high as, for example, for contrast or for the TE study. Now we're moving to spectral Doppler again, to pulse wave Doppler, and it is a standard procedure to always image the mitral valve with spectral Doppler as well to look at the flow pattern. Basically to look at, for example, the ratio between the E and the A wave, the deceleration of the curve, also for the measurement of the parameters that we will then need for the so-called E to E prime ratio. We'll talk about all these issues when we look at diastolic dysfunction. But from a technical point of view, it's important that you place the transducer or place the sample volume right at the tips of the leaflets, usually more to the left than to the middle because the posterior leaflet is a little bit shorter. Let's take a look at that in our next demo. To acquire a good signal of the mitral valve inflow, it's very important to have good image quality. So if you have a good 2D image, usually your Doppler images will also be good. Vice versa, it is sometimes still possible to achieve fairly good Doppler quality even if the image quality is not so good. But nevertheless, it's first important to optimize your image. So this is an optimized four-chamber view. And just to demonstrate where to put the sample volume, I want to put the color in first.
just to show you what the direction of flow is. In the normal ventricle, which is not dilated, the flow is directed more towards the lateral wall and then turns around and goes towards the LVOT. So to place your sample, you have to consider this, and also consider that the posterior leaflet is shorter than the anterior leaflet. So this is the region where I have the sample volume now, where I would place the sample volume. It's not in the middle of the ventricle, but it's more towards the lateral wall. The next thing that is important is it's better to freeze the 2D image while you perform the post-wave Doppler. You can use the image as a reference, but in the long run it is probably better, if you want to then do some measurements, to freeze the image, because the quality of the Doppler is better if you freeze the 2D image. You can optimize the image. I would always want to see at least some information below the zero line, between the baseline, and then also optimize the velocity so that you get the entire spectrum, but nevertheless that you do not have unimportant information on the spectrum. So the location of the sample volume you can control. If you move the sample volume towards the mitral valve, what you usually get is you get very sharp echoes. And these echoes are caused by the valve itself, which closes, and you're right in the valve, basically. So this is probably too far down. So you'd have to move the transducer up a bit until these very sharp echoes vanish. And then you would freeze the image and perform your measurements.
The normal values for mitral valve Doppler are 0.8 to 1.3 meters per second for the maximum velocity of the E wave. Of course, if you have a velocity that exceeds this, you have to consider that a pathology might be present. So much about the mitral valve. In the next lecture, we're going to talk about the mitral annulus, the aortic valve, the LVOT, the pulmonic veins, and many other things that you can do with Doppler, both spectral and also with color Doppler.